up, guys? So welcome to this video, which is shock. Surgery like shock is very important. So about shock, what shock actually means is that ischemia on a large scale is what shock means. So whenever a specific organ is starved of blood, it's going to be very dangerous for the organ and ultimately for us as well. So when it occurs as a large scale, it's going to be very crucial for the survival of the particular host. So in this video, we're going to see a lot of aspects about the shock, like the pathophysiology, the components of it, the various types of it, the stages of it, severity of it, how to treat it, which is the best modality of treatment, when to stop resuscitating the shock, and so on. So stay tuned. Okay, so what shock does to the body? So what happens is there is reduced tissue perfusion, which is nothing but ischemia on a large scale. It is similar to our expression when our monthly salary gets cut. Oh my God, I'm shocked. So that's what happens here too. What we know already is that the blood, there are these blood vessels, which are nothing but the tubes which carry blood to the various organs. So that is normal, which is when we are happy, as seen over here, which is when we are happy. And after that, we have this, yeah, similarly. So there's this job containing company from which money comes, and the man is happy, which is normal, right? And after that, there's something called shock. When shock comes, then the blood flow is either reduced or it is a very much, no blood flow is there at all, which is why the organ is sad. It is similar to losing a job and going bankrupt, right? There's no money, so we are sad, which is what happens in shock as well. So pathophysiologically, there are various paths of shock, such as the cellular, the microvascular, the systemic, and the ischemia reperfusion syndrome. Let's see one by one. So in the cellular component of shock, there is this reduced tissue perfusion, which is a key point in shock. Due to this reduced tissue perfusion, the tissue which are going to receive oxygen along with the blood, they are not going to receive any more oxygen because there is no more blood. Normally what happens is that glucose and oxygen will together be inside the cell, and it is going to do metabolism and excrete CO2, which is called the aerobic respiration or aerobic metabolism. But what happens in shock is that there is no oxygen, which means only glucose is available. But glucose cannot be utilized without oxygen in aerobic metabolism, which is why anaerobic metabolism comes to play, and lactic acid is going to be synthesized here. So this lactic acid will cause metabolic acidosis, given by the mnemonic MAC, metabolic acidosis. And so ultimately what happens is that after some time the lactic acid level is going to become very high, but the glucose level is going to become very low, which is why, so what happens is that normally when the glucose is present, the sodium potassium pump is very good, very successful in transporting sodium and potassium and all, and maintaining the membrane integrity. But in shock what happens is that the glucose level is gone, the glucose is very low now, so the sodium potassium pump is also gone, and after that the lysosomal membrane will rupture, which in turn will release the lysosomal enzymes, which causes lysis of the cell, which is when the potassium, which is normally intracellular, comes out into the blood, which is why during shock the potassium level in the blood will be very high. And then there are a few microvascular pathology which occurs during shock. So there is reduced tissue perfusion, which is a well-known fact, which is in shock. So what happens is that this reduced tissue perfusion will stimulate immune system and coagulation system as well. Both these two together will stimulate the production of free radicals, otherwise called the reactive oxygen species, which in turn are very much damaging to the host, right? Just like the rose has a lot of thorns, this rose is going to be very, like it's going to behave like a thorn to the endothelial cells, due to which the endothelial cells get very leaky. After that, it's going to let the fluid escape from inside of the vessel, which we call edema. And next is the systemic. Systemic, we have three main organ systems: the heart, the kidney, and the lungs. The brain is also one of them, but let's not talk about it now. So in the cardiovascular system, what happens is that there is first reduced tissue perfusion, which in turn is going to stimulate the heart. So this reduced tissue perfusion is manifested by low cardiac output, which is a product of which is a product of stroke volume and the heart rate. Stroke volume is going to be reduced because the heart will not be compensating for that because it's hypovolemic shock, guys, which is why there is no volume inside the blood vessels at all, which is why tissue perfusion is slow. The main problem here is there is no volume. So stroke volume, there is no point in compensating for stroke volume because it is not possible, which is why compensatorily the heart rate is increased. So what happens when the heart rate rises is that the cardiac output will ultimately rise, just as shown over here. So once the cardiac output is increased, it is somewhat compensated to the shock, right? Okay, the next thing is that this reduced tissue perfusion is going to stimulate the sympathetic system. Sympathetic system is going to stimulate the heart and it will cause increased cardiac output in addition to causing systemic vasoconstriction. That's what happens in CVS. Let's go to the respiratory system. So there is tissue perfusion which is reduced. It will stimulate the respiratory system because the sympathetic system is stimulating it, which in turn causes increased respiratory rate. That is the main compensatory mechanism. Also, not to say again that the tissue perfusion is very low, which in turn is going to cause the metabolic acidosis. This acidosis needs a compensatory alkalosis, which is brought about by the lungs. And at the kidney, there is low perfusion. Kidney is a organ which is going to take in a lot of oxygen from the heart, which is why the kidney is going to suffer a lot. In kidney, there will be reduced urine output. So it's basically because there is a reduced GFR. And then what happens is that this kidney is going to stimulate this renin-angiotensin-aldosterone system, which is a compensatory mechanism. It is going to cause a stimulate constriction of the blood vessels and a sodium and water reabsorption. When sodium and water is reabsorbed, the vascular volume, the intravascular volume is going to become a bit high, which is a compensatory mechanism, by the way. Another system is that endocrine system. In endocrine system, the tissue perfusion is very less, which in turn releases the ADH and aldosterone and cortisol. All these three will together increase the sodium water reabsorption and increase the volume and also the sympathetic vasoconstriction. All these things are the same, guys. And the next one is ischemic reperfusion syndrome. Well, this is a bit different when compared to the all the above said stuff. So what happens in shock is that there is metabolic acidosis and hyperkalemia. What happens during reperfusion, meaning the person is in shock. After a while, the doctors are giving him reperfusion through either IV fluids or through actual blood. What happens now is that all these acid, this lactate and the potassium, all these things will be released from the particular organ site and it is going to enter the systemic circulation plus some more lactic acid which is accumulating inside the cell, some more potassium also comes out when the blood flow is restored, which in turn is going to cause a suppressant action on the myocardium and dilatation of the blood vessels, which in turn will reduce the blood pressure, exacerbating the shock. So to summarize, there is so to begin with, shock is nothing but reduced tissue perfusion. Compensatory mechanisms include increasing vitals like the heart rate, respiratory rate, volume, intravascular volume is increased, and urine output is reduced. Other compensatory mechanisms include vasoconstriction, which in turn is manifested by cool peripheries, and other manifestations include metabolic acidosis, hyperkalemia, edema. Let's classify shock. The mnemonic to classify shock is H code. H code stands for hypovolemic, cardiogenic, obstructive, distributive, and endocrine shock. So what happens is that in hypovolemic shock, which is the most common shock by the way, the circulating volume is reduced. So anything which is going to cause reduced circulating volume, that is going to cause hypovolemic shock. It can be of two types, hemorrhagic and non-hemorrhagic. Then the cardiogenic shock. In cardiogenic shock, which is primary, it's a primary disability of the heart to pump the blood, which occurs as a result of arrhythmia or myocardial infarction or valvular heart disease. Obstructive shock is due to a mechanical obstruction to the cardiac filling. For example, if the layer which is surrounding the heart has a lot of fluid, as in cardiac tamponade, then there is a mechanical obstruction. D is distributive shock, which is due to the distribution of the whole organ, whole blood into various organs which the blood is not necessary at that point of time. It occurs in septic, anaphylactic, and neurogenic conditions. The last one is endocrine shock, which is a combination of hypovolemic and cardiogenic shock, or hypovolemic and distributed shock. It occurs when the thyroid hormones are high or low, or when the adrenal hormones are very low. And severity of the shock. So first there is this compensatory mechanism which happens, which is why there are five types of severity of shock. One can be compensated, the next is decompensated, next is mild, moderate, severe. And in a compensated shock, it is all compensated, which means the shock is compensated, which means that the important organs of the body, which is the heart, the lung, the kidney, and the brain, all receive adequate blood supply. That is called compensated shock. Decompensated shock means that more than 30 to 40% of the circulating volume is lost, which is when the compensatory mechanisms are overwhelmed. In mild shock, the vitals will start increasing, like the heart rate, respiratory rate will increase, the urine volume will slightly reduce, and the person will be having anxiety, and yeah, the and also vasoconstriction occurs, which is causing cool peripheries. All these things are common for all the shocks except for septic shock, in which there is a lot of inflammation and the person is warm, fever. Moderate shock, in addition to the above findings, the urine output is going to be further low, reduced to less than a 0.5 ml per kg urine. Well, the number is not needed, but there is significant urine output reduction. And BP will be reduced in moderate shock, and in severe shock, BP will be so reduced, and there is a zero urine output. The mental status in mild shock is just anxiety, whereas in moderate shock, it's going to be the person is confused and drowsy, and in severe shock, the person is unconscious and labor respiration is also seen. There are, however, a few pitfalls in monitoring the severity of shock. First one is capillary refill, and then the blood pressure and the heart rate. And then there are a few consequences of shock. There are only two consequences: unresuscitatable and multi-organ failure. Unresuscitatable means we will not be able to resuscitate the person at all. It is due to prolonged and profound shock. The person will become no longer respond to treatment. It's otherwise called the point of no return. Multi-organ failure, it is due to prolonged shock alone. If more than two or at least two organs are screwed up, then we call it the multi-organ failure. About resuscitation, first, immediately after the diagnosis, we are going to immediately say that it is a hypovolemic shock, following which fluid resuscitation is done. This is the safest approach. Thinking all shock or hypovolemic shock is the safest approach. So first we do fluid resuscitation. If the person gets better, it's very good. But if he does not get better, then it suggests hemorrhage, which is why immediately we have to switch our plan of action. The person is taken for surgery with parallel resuscitation. And the next one is the bowel obstruction, where resuscitation should be performed before the surgery, not concurrently. About the fluid therapy, first thing we need to know is IV access. IV access should not be long, it should be short and a whiteboard catheter, which is the preferred one. There are some different types of fluids. The first fluid which we want is the crystalloid. Crystalloid, the examples of crystalloids are given below. Normal saline, Ringer lactate, and Hartmann solution are the crystalloids. Crystalloids are better than colloids in that colloids are very expensive and side effect profile is very high. Well, however, crystalloids are not the mainstay of treatment. Until the blood arrives, we are going to give crystalloids. Once the blood arrives, we give blood to correct the blood loss, because blood is always superior when compared to crystalloids, because crystalloids cannot carry oxygen to all the parts of the body, which is why blood is very important. Hypotonic solution can also be given, but only for specific diseases. For example, in diabetes insipidus, we can give hypotonic solution. And sodium overload, which occurs in liver cirrhosis, also necessitates the need for hypotonic solution. There are certain examples for this. Crystalloids, normal saline, Ringer lactate, and Hartmann solution. For colloid, albumin containing solutions are colloid, and the hypertonic solution is dextrose. Okay, once we give IV fluid, we need to monitor the response, which is called the dynamic fluid response. Person is categorized as three things. one of the three things: a responder, transient responder, and a non-responder. So there are three features using which we are going to categorize these people: improvement, the duration of improvement, and ongoing fluid loss. The responders have good improvement, and transient responders will have good improvement, and non-responders will have no improvement at all. But a responder, the improvement will be sustained, whereas in a transient responder, the person reverts back to the original state before as in the state before resuscitation. In non-responder, though, there is no improvement at all, so no, not at all talking about time. Ongoing fluid loss is not present in a responder, whereas moderate ongoing loss is there in a transient responder, and major loss in a non-responder. So we are going to do some resuscitatory measures such as giving vasopressor support. For distributive shock, catecholamine is given. Catecholamine examples include phenylephrine and noradrenaline. But however, when these two are not sufficient, or when the person continuously, does not get better, we give vasopressin. Vasopressin is very good. For cardiogenic shock, dobutamine is the first line treatment. Monitoring, minimal and additional monitoring are very essential. The minimum monitoring is the minimum help we are doing a patient. So it involves pulse oximetry, the blood pressure monitoring, the urine output, and the ECG as well. Additional monitoring include the central venous catheter, invasive blood pressure monitoring, cardiac output, and the base deficit and the cardiovascular system. In the cardiovascular system, if the shock is not corrected rapidly, we need to do invasive blood pressure monitoring and also central venous pressure. Both are important. In CVP, that is central venous pressure, the normal response which we need is improvement by 2 to 5 centimeter water in 10 to 20 minutes, and in it will drift back to normal, that is the pre-resuscitatory state, in 10 to 20 minutes. What is abnormal is when this is persistently high or low. This kind of shock, which causes high CVP, is that the patient is means full of water. It signifies there is a cardiac overload. But if this CVP is very low, that is persistently low, it means the person is empty, means the person does not have any blood. The circulating volume is nil or very much low, which is why we have to give them fluids or blood. Cardiac output is measured using various things like the Doppler ultrasound, pulse waveform analysis, indicator dilution methods. All these three things are very helpful in distinguishing between hypovolemic, cardiogenic, and distributive shock. Systemic perfusion is measured by base deficit and lactate. And also mixed venous O2 sats, that is oxygen saturation. The base deficit and lactate are very sensitive markers to both decide the treatment and also to monitor the response to treatment. Normal values are less than 6 millimoles per liter, beyond which it signifies significant morbidity and mortality for the patients. Mixed venous oxygen saturation, the normal value is 50 to 70 percentage. If it is less than 50 percentage, it suggests there is hypovolemic shock and a cardiogenic shock. And if it is more than 70%, it is a rule that it is septic shock. The reason why it is so much increased is that there is disordered utilization of the oxygen at the cell level, because see, in septic shock the cells are all screwed up, so even if the oxygen is very high, the cell will not be taking up enough oxygen, right? So what happens is the body is trying to give the cell more oxygen, but it is not taking up, which means oxygen which we are detecting is very high. That is mixed venous O2 sat. Other methods to diagnose organ perfusion, the extent of organ perfusion, include: for the muscle, we use NIS and TOW. NIS stand for near infrared spectroscopy, and the TOW is tissue oxygen electrode. The same thing is used for the brain as well, except that including these two things, consciousness level is also very crucial in the brain. In the kidney, urine output is seen, and in the GIT, starting from the mouth, there is sublingual capnometry, and in the GIT, the gut mucosal pH and laser Doppler flowmetry is also very helpful. The end point of resuscitation, the last part of the day, that is, there are two types of endpoints: traditional one and the global perfusion endpoint. Traditional endpoints are the normal vitals like the pulse, the blood pressure, and the urine output. But however, these are not very good, which is why we have another indicator, because all these things will reflect the normal vital. See, pulse will signify something about the heart. BP also is about the heart. Urine output is about the kidney. See, one thing which is common is that all these organs, like the heart and the kidney, right, these organs are going to receive adequate blood supply even at the last moment, which is why the actually the gastrointestinal tract and like the skeletal muscles, even if their vascular bed contains very less blood, it will not be shown by the traditional methods at all, which is why we can't rely on these traditional methods to think about the endpoint of resuscitation. So they call this as occult hypoperfusion, meaning hypoperfusion is present but it is not visible to us clinically. Global perfusion is very good. Global perfusion is what we just saw, like the base deficit and lactate, and also mixed venous O2 which is what we are using nowadays. And that's it. See you soon, guys. Keep revising from Bailey and Love. It's a very good book. Thanks.